So welcome to this session about practical guidance for care partners. My name is Malin Legat and I'm an occupational therapist from Stockholm, Sweden. So I beg your pardon if my English isn't that super.
My name is Ruben Pagkatigunan, physical therapist at Johns Hopkins Stadium Medical Center. I see some of my patients here. I work at the Myositis Center over there with Dr. Cha and other PTs and OTs. I also work in other clinics, neuromuscular clinics at Hopkins, but main specialties in myositis. I participate in some clinical research over there on the side, and I've been a physical therapist for many years. So before we start, I would like to mention the disclaimer. The health information provided in this presentation is provided for general informational and educational purposes only, and is not a substitute for professional health advice. Please encourage you to consult your physician, PTs and OTs regarding your mobility needs, and we do not endorse any equipment or recommend any of those mentioned in this presentation. We do not have any financial interest in any of the products and the vendors.
So these are the topics that we will cover for this session. This session is about educating the caregivers on moving their loved ones safely. Since caregiving involves physically demanding tasks, we will talk about how to be a healthy caregiver. So you heard a lot of exercise in myositis, but also the caregivers need to exercise. We will talk about what proper body mechanism is and how to use correct body mechanism when lifting and transferring your loved ones. We will also show you different transfer and bed mobility techniques, positioning and different ways of getting up from the floor. And at the end we will cover different transfer and mobility equipment that can assist caregivers with transfers. So caregiving can be physically and emotionally.
Can you speak a little bit louder, please?
Should I put it closer? Is it better?
Yes.
Or not? I was doing this yesterday, or I was supposed to. So caregiving can be physically and emotionally demanding, and it can put a great deal of strain on your physical and mental health. So we want you to be a healthy caregiver. As caregiver, you may find yourself with so many responsibilities that you neglect taking good care of yourself. The best thing you can do for the person you are caring for is to stay physically and emotionally healthy. When your needs are taken care of, the person you care for will benefit too. So be strong and stay fit. I know you juggle many roles and you do as much as you can, but take the time every day for a physical activity you enjoy. It can be as simple as spending 10 minutes walking around the neighborhood. So moderate intensity activities, even in small increment, can boost your energy levels, reduce stress, and help you maintain a healthy weight, and can help you keep your blood pressure and cholesterol at healthy levels. Eat well. A healthy diet will give you more energy and help prevent other health problems too. So keep up your energy. Emotional energy. Finding strength as a caregiver means more than staying strong physically, but also mentally and spiritually. The stress and strains of providing care to loved ones may take a considerable toll on back, so take care of your back. It is important for caregivers to learn and apply proper body mechanism when lifting, transferring, or even when helping to repositioning a loved one. We will talk about body mechanism in the upcoming slides.
So be strong. Because of the physical demands of caregiving, it's important to keep your body strong. It is important to have a regular strengthening program that works for you and that you enjoy. It should be easy to do at home, and it should target specific muscle groups such as your core, your abdominal muscles, the glutes, the thigh muscles, the shoulder and upper arm, because those are the muscles that you primarily use when you bend, when you lift, and when you transfer your loved ones. To be effective, the exercise program must be done regularly, at least twice a week, with a day of rest in between so you can recover. As with any exercise program, you should start with something you can tolerate. Start with a low intensity, high repetition type of exercises with a gradual progression of exercise intensity. So you may want to start using an elastic bands in the beginning, and then as you get stronger, you gradually transition to using weights. Do not forget to stretch before you start exercising. As I mentioned, focus on the core muscle groups. These are very important muscles that help protect your back as you perform your caregiving task. If you have any history of soft tissue injury or any type of surgery and you're unsure how to start an exercise program, ask your primary care physician to refer you to your local physical therapist that may help you to, design an individualized exercise program that works, to your medical condition. Stay fit. In addition to a strengthening program, it is also important to incorporate aerobic type of exercises in your daily routine. This can be as simple as, as walking outside, working in the yard, or attending a Zumba class or spinning class, It should be fun. It should be something that you enjoy doing. And how long should you exercise? Well, according to the U.S. Department of Health and Human Services, the 2008 Physical Activity Guidelines, it should be at least 30 minutes, at least twice a week. And to be effective, a person, it should be 30 minutes twice a week. And how hard? Moderate. That means 30 minutes, at least 30 minutes of accumulated moderate level of activity. So the exercise doesn't need to be continuous. It can be accumulated. It could be done in shorter bouts throughout the day. For example, 10 or 15 minutes intervals. You can include even your caregiving tasks as one of your exercises because it helps with the when you do those repetitive lifting and twisting and stuff. Those are type of exercises as well. Moderate intensity means that you feel warm and you feel slightly out of breath. And a simple way to monitor an exercise intensity is to use this talk test. So in general, if you're doing a moderate level intensity activity or exercise, you should be able to talk, but not sing during the exercise. So, but if you're doing a more vigorous type of exercise, you won't be able to say more than a few words without pausing for a breath. So, that's like a general rule.
So why is it important to keep healthy? So studies have shown caregivers are at increased risk of experiencing musculoskeletal symptoms of injury. And the incidence of low back pain was higher among caregivers compared to their peers of the same age and health conditions. Transfers, lifting, and patient repositioning are the most common tasks associated with musculoskeletal injury, particularly back injury. So the most common causes of back injury are lifting a heavy object incorrectly, twisting the spine while lifting, sudden jerky moves while lifting, poor posture or poor body mechanism over time. So unlike nurses and PTs and OTs who have formal training on how to move patients safely, most caregivers are non-professional which do not have the knowledge of the back safety and lifting techniques. This may be leading cause of low back pain.
So your lower back is really prone to injury because it bears most of the weight while performing these daily activities of bending, twisting, and lifting. So in order to minimize that risk of back injury, it is really important to practice good body mechanics. So what is good body mechanics? It means placing your body in a correct position so that you maintain the normal curves of your spine while lifting, transferring, or moving a person. So as you can see in the picture of the spine, You know, our spine has natural curves. You know, it's divided into different parts. You can see the cervical, there's like a C-shaped curve there, then the thoracic, like a hump, and then the lower back, which is the area where, you know, receives a lot of stress when you bend or lift. It has this natural curve, which is we call the neutral spine position. And you have to maintain this neutral spine position because this is the most stable position of your spine. You know, when you do the lift. As you can see in the picture over there of a person trying to lift a water bottle with a check mark, that's the neutral spine position. You maintain the natural curve of the lumbar spine. And you don't do the one where you bend on your back because you lose that natural curve. And that puts your back at risk of injury, like, you know, strain or disc herniation and stuff like that. So remember the neutral spine position, and the one way of remembering it to do is not to bend on your back, but bend on your hips and knees when you start to lift a person. So why is it important? Again, to learn body mechanics, it shows safety of caregiver and patient. It reduces strain to the muscle of the joints, and it prevents injury. And also, it is more efficient and less tiring to you know, use correct body mechanics, you know, when you transfer and move a person.
So going through it a little bit more in detail. So these are the principles of good lifting techniques using good body mechanism. So the primary rule is to maintain the normal lumbar curve, as Ruben said. So maintain a wide base of support. Keep good posture and maintain a neutral spine position. Avoid bending and twisting. Instead, bend at the hips and knees, not with your back. Tighten your abdominal and use the stronger leg muscles to do the lifting in one smooth movement. Keep the load close to your body while keeping your back straight. To turn directions, use your feet to pivot, do not twist. And plan the move. Clear the pathway of obstacles and see what you can and cannot do. Know your limits and ask for help. If you're helping someone transfer to a wheelchair or to a commode, tell the person what you are doing or going to do and encourage them to help as much as they can. Is this all recognized? Yeah, you all know about this? Good. So now we're moving on to the specific transfer and mobility techniques. We will talk about med mobility techniques, different types of transfer, how to assist someone with repositioning in the wheelchair and chair. And then we will talk about techniques on how to get up from the floor. And please note that you may have to modify the techniques that we will show you to accommodate your specific situation. So, moving up in the bed or getting higher up in the bed. Is this too easy for you or is this good? It's fine. Good. So what you do is that you bend your knees, lift your head and the pelvis, and put your elbows in the bed as you can see, and then press back. So that is how you can get higher up in the bed. You can also use different materials that will make you glide more easily. So satin pajamas and satin sheets. Yeah, why not? Also turning around in the bed. Lift your knee, pull it over, lift your butt to the side and just use your the weight of your body to get the rolling motion. Getting up from lying to sitting, you continue where you are at the side. Let your legs fall down to the side of the bed, which will be like a weight that will help you up, and then press with your arm. And if someone is helping you, it's kind of the same position as when you're getting up by yourself. So remember, it's important for the helper to have a good base that we were talking about, the spine straight, and using the strength of your body instead of the arms. Yeah.
So I want to add something here. So when I'm in a clinic, especially for my IBM patient, usually they end up having like weakness in their triceps when they get up. So sometimes it's nice to roll onto the side, the stronger arms. And you use that arms, you should use the stronger arm to push up. And then the person helping will be assisting right there. So that will make it easier. And then don't forget to swing the legs because that will give you some kind of leverage to pull up. So before you transfer a person, it's important to check the environment. As Malin said, eliminate any barriers or safety hazard, take away any loose rocks out of the way to prevent slipping, remove any clutter, leave enough room for the two of you to move freely. Get the equipment ready. Make sure all the equipment are in good working condition. Set them up. Have the surfaces you're transferring to and from as close as you can. And beds and other equipment should be adjusted to proper height. Plan the movement, think through the steps. Get the help you need. If you're not able to help the person by yourself, ask for help. And lastly, prepare the person. Explain the steps to the person and what you're doing and what you're going to do. Talk through the process and encourage them to help as much as they can. You know, if you have a gait belt, I would encourage you to use a gait belt because it will give you a good grip for the patient. So these are the different transfer techniques that I will demonstrate to you with one of my patient models. So these are the three basic techniques that I use in the clinic. The stand pivot transfer technique, the squat pivot, and the slide board transfer. And may I call my model to come up here? Hello, do you hear me, guys? Okay. Backing up. And you come up here facing this way. Try to, you can, yeah, a little bit closer to the bed, and I can move it. Gait belt. So I use this gait belt a lot for transfers. The only time I don't use a gait belt is if the person has any kind of like surgery or anything that doesn't allow them to put any pressure in the abdomen. If they're like anything here, like surgery or anything, or it's healed, I usually put it above the abdomen, like around the chest. You're okay? Yeah. Put this belt around you. You're okay there? Yeah. Not too tight? No, not too tight. There. Oh, there you go. Oh, I got front there. You're going to take with me on the transfer. Thank you for telling her. There you go. Okay, so I'm going to, this flips up then?
Yes.
Thank you. So the first thing I usually do is, for this type of transfer, I would like you to use that.
Use that?
Yeah, to push on. There you go. Good. So first thing is, I will ask the patient to scoot forward. And this is turn on. Good. And you know, for the transfer, I usually position the stronger leg closest to the bed, because you know when we stand up and pivot, it's a lot easier to turn a patient with a stronger leg next to the bed. You know, so is there like, let's pretend it's your strength. So go ahead and scoot. You're okay there?
Yep.
Good. And use proper body mechanics, right? So bend on your hips, keep your back straight, and then for this transfer, I usually move the knees closer to the bed, so they're ready there, they angle, and then I can just ask you to get up, help me as much as you can at the count of 3. Okay? Lean forward. 1, 2, 3, and push up. Hold on to me. Okay?
Yep.
And then go ahead and turn, pivot. Good. And then before you go down, reach back, and then slowly go down. There we go. Perfect. Good. So if you have another person to help you, let's say you guys can do it this way, like bed, wheelchair to bed, you can have one person each side helping the patient, you know, because sometimes this is difficult to do on your own, especially if the patient cannot help you because of like leg weakness. So let's say you're transferring from the bed to the wheelchair, and another person will be kind of like behind her, and then I'll be helping you to get up.
Okay.
Turn and pivot, reach back to the armrest, and that's it.
Okay.
Okay, I want you to scoot forward, man. Good. Count of 3. Neutral spine.
Okay.
Ready? 1, 2, 3, and up. Good. Turn. Step back a little bit. The other person helping me will be kind of like holding onto the gate belt here. Reach back. And down.
You guys are hired.
You're hired?
That's one.
You're hired.
Oh, okay.
Yeah.
Any questions with that?
So what I do,
Yeah. Go ahead.
What if you're the only person? So you can do this by yourself if, I mean, you just have to be careful, right?
Yeah, I think the main thing with this transfer is really having the person scoot forward, so your center of mass is like over the toes when they lean forward. You know?
I'm 5'4", my husband is 6'2". I won't say my weight, but he's 220 pounds. The way the PT people told me, and I was really risky, but it works. I stand in front of him, like this morning, getting him out of his walker to the bed or from his whatever. I put his legs between mine,
Yeah.
and then I use the gait belt, and it's amazing. I bring him up, and his knees go against my quads.
That's right.
He's strong, and then when he's able to lock his knees, he can stand.
Yeah.
And I can do that without hurting my back, because I
That's-
used to stand behind him and try to lift him up.
No, that's
That's
one.
whole never
So-
do that.
So with that one, it depends on the level of fitness or
Right.
the stages of IBM if you have IBM. The stronger you are, you can do this standard way of transferring without me, squeezing the knees between my thighs. However, if the quad is getting really, really weak, the patient tends to spread their legs to get up because they compensate by using their hip muscles to compensate for the quad weakness. So in that case, you cannot transfer the patient with their legs out. It's harder for both of you. And your technique is really nice.
Yes.
I do that a lot too. I usually put them here,
Yeah.
squeeze it like this, have them lean forward, and then count of 3 up, and then transfer over.
It works good for us
Yeah.
because of his height.
Yeah.
And I'm shorter, and
Right.
his knees hit me right here, and they're strong, and I
Mhm.
can lift them
Yeah.
with the gait belt.
With the gate belt. Right. Thank you.
That was what I wanted to say.
Something important too, when you're going into bed, make sure you're putting them pretty much where you want them in bed, or
Yeah.
a little higher.
That's true.
It saves you a whole lot of
Yep.
energy.
So they don't have to scoot out.
Yeah, because scooting up is another energy.
That's true. That's a good point. So that's good to know. If you're transferring here, pillow there, move over a little bit so that when I put you over, you're right in the target. So that's a good question there. Any other questions with this transfer? Okay. Moving on.
Well, just another thing, but you
Yeah.
guys probably know, you find out by doing it, is making sure that whatever they have on their feet isn't slippery.
That's true.
Exactly. People forget
Exactly.
that sometimes, or there's not a rug that's gonna move.
Yeah.
Because I learned all this, like,
Yeah.
yeah.
Make sure the dog is someplace else.
That's good, yeah. Excellent, yeah. Yeah.
I have one question.
Yeah.
How wide should the belt be?
How wide?
Yeah.
You mean like,
Is that a standard width belt right there?
yeah, this is a standard one. You can get a longer one.
I just meant the width.
Oh, the width, pretty much is the standard one we use, you know. I know you can probably get, you know, something out there with a wider one because
It should be at least that wide.
at least it's wide, yeah. Wider will be better because it's less pressure.
Can you show people how you actually do that? Because it's not always
Which one, man?
intuitive. How you put the gate belt on.
Oh, yeah.
Because you do it all the time, but when you go
Right.
to do it, it's like not always intuitive.
So for me, wrap it around. I usually put it, you know, if you feel the pelvis here, there's a bone right here. That's where you put it on top of that bone. So like around the navel area, tighten it up. Not too tight. You should have enough space for your hand to grab the belt and just tighten it up.
I've seen belts with handles on it.
That's, yeah.
Is that better?
That's better actually with the hoops in the back, yeah. Yeah, I use that too. Because you can, that's a good one for cape training when you were walking a patient. Instead of hooking your hands under here, you have the hooks, the little loops that you can hold on. Yeah. Put it back
The
in.
one issue that I've had with the gate belts that have the loops is
Uh-huh.
that the loops are big enough that now my hands are well above the belt.
Oh.
Just something to think about when you're
Yeah.
putting the gate belt on there,
Mhm.
that it's
It's harder to control or
a
it
little
gives you
bit
less
harder to
control.
control. but
Less
it's-
control,
It's
yeah.
just something to know that,
Yeah, especially for like myositis patient who have more leg instability and you really have to really get a good grip. The loops may not be a good one for you.
but it's also better, it's easier to
Easier
hold
to
this
hold.
way than to hold
Right.
that. So it's
Yep.
trade-offs.
Yeah, there are trade-offs there.
So I think we're gonna-
Yeah, this is the squat pivot transfer technique. So I use this technique on patients who cannot fully stand up because their quads are so weak. So the only position they can get into is the squat position. So basically the same thing, you ask the patient to scoot forward. And for this, if you can remove or flip this armrest away, out of the way, it's a lot easier. So for this technique, I'm going to incline a little bit, get it like this, okay? Just let me scoot it for you. Good?
Yep.
Once you do with this, you want the patient to really like lean forward, put the center of mass over their toes. I'm squeezing the knees because with this type of transfer, the patients are weaker. So what I do, 1, 2, 3, and scoot. No, you don't have to. Just like that. So basically, you can sit you up a little bit more. So if I'm here, when I do it, the patient will do like a squat pivot transfer. You can do it in different stages, not just like one quick move. As long as you move the wheelchair really close, and you can do it like maybe 2 steps, 1, 2. If you're having another person help you, so the person will be behind, and then same thing. It's hard. And you can pretend like
It's a big bed.
yeah. And lean forward. And ready. And 1, 2, 3, and up. And go scoot. Perfect. You can. This is not your transfer.
No.
Because you can still stand up. So.
Okay.
Thank you, ma'am. So, any questions on this one? Move on to the next one.
Are we gonna talk about those? Should we?
We can a little bit, maybe. This is like.
So, well, I don't know. You don't hear me, right?
We can hear you. I can hear you.
You can hear me.
Yeah.
Very close. So maybe, okay? Yeah. So we've been scooping all over. So this is a way to get a person better up in the chair or the wheelchair. And I would say it's the same kind of technique, or as we have been doing. So instead of trying to get the weight on the feet, moving forward and then pushing back. So instead of pushing to the bed, we are pushing back into the chair. Yeah. So make sure the chair doesn't move.
Sometimes, with this technique, in some IBM patient, instead of doing this, you can use the leg, your knees to push back like that to help them scoot back. Or sometimes I stay behind them. I use like, if they're sitting on a sheet, I go like this and then go a quick pull, scoot them back.
Exactly. And then you can also, you can make like a butt walk, as we say in Sweden. So you scoop to the one side and then scoop to the other side and try to get your butt back. Or your bottom. What do you say? You don't say.
It's good. You're good.
So, and if you are two people, so what you do is that you ask the person to lean forward to your shoulder, and that's actually what Ruben was talking about. So either you take hold of the clothes, or if you have or the belt, or if you have your sheet. So that is actually how you can do it.
Okay. So if the other techniques doesn't work and the patient cannot even squat or stand, I use the slide board transfer technique. So I brought with me two types of sliding board. We have the regular type, and then we have this other type. It's called the busy board. We got like this disc that moves around. So I'll show you how to use the regular sliding board first. So let me just move this closer. So I'm gonna have you scoot forward one more time. It's a little bit forward. That's good. And what you do is you put this underneath the patient's buttocks, knee, put it there. So it's like a bridge between the wheelchair and the bed. And make sure, when you ask the patient to put it on the board, don't put their fingers underneath the sliding board. They will pinch it, make sure it's on top. And before I do the actual transfer, I explain to the patient that we will do it in maybe 2 steps, 2, 3 steps. I'm going to have you lift and scoot until we get to the bed. Okay? So with this, I usually put their knees together, kind of like lock the knees like this, and then have you lean forward. Count of 3, I want you to lift and scoot. Ready? 1, 2, 3, up and scoot. 1. Another one, 1, 2, 3, good. 1, perfect, that's it. Give it some time to rest. So, if you're using the other busy board, the other board, it's a little bit heavier. It slides. Put it like this. You good, man? Yes. You're sitting on the disc. Somebody stabilize this, and you slide yourself in several circles. 1, 2. It's pretty good, but in patients who are more dependent and they're pushing all their weights on the disc, it's a lot easier to slide. So thank you. Any questions so far?
Where does one acquire one of these slide boards?
What's that, sir?
Slide board, where can I get that on Amazon?
Yeah, you can get it on Amazon. It's called, I'll show it to you later on the other side. It's called Busy Board, like B-E-A-S-Y. B as in boy, EASY, busy board. Yeah.
Okay, when I first, I think 2 years ago when I came, they told me to do this hold underneath one side and lift. But are you saying that's not good?
What is that meant like?
Under the armpit?
Oh, this one?
No, it'd be only one side.
Oh, just one side?
No, the other arm on that side. Like,
I'm sorry.
like this. Like that.
Oh, like that?
And I almost killed myself.
No, this is harder to do. Yeah,
Yeah,
it
okay.
moves.
It's also not good for.
It's not
Not
good.
for their shoulder and his back.
Yeah, you don't want to pull on their arms because there are lots of nerves around there that you can pull. Yeah.
That's one of the problems we had in some terrace. When our sons tried to help initially, they didn't have the right technique because they were going to muscle it. And they were pulling on Marilyn's arm. And they were actually hurting her arm.
Yeah.
Trying to pull her up. So we go around her, under her arm, we're actually on her shoulder blade.
Yep, that's
That's what we're using to pull her up. And we taught our sons how to do that, so they do it that way now.
Another thing is you don't want the patient to be pulling on your neck
Right.
because you can hurt your neck. So the most stable part to put your hands when you're trying is to put here on the shoulder blades because those are the spine, the ribs that it's really really strong. So so we're done. Okay, we're actually done.
Oh, okay.
Thank you so much.
You're welcome.
Let me help you with this. Oh, forgot the belt.
I think the belt goes to the model.
Can't get it. Anything else? Again. So I will show you three techniques in getting up on the floor. But before you move a person who has fallen, it is important to check the person if it's injured. You can hurt the person more if something is broken. If the person is unconscious or appears confused, maybe there's a head injury there, or there's bleeding or severe pain, call 911. Only attempt to help the person if you feel that both of you are able to safely work together. If the patient is not hurt and able to move, you may assist them with getting up from the floor using these three techniques. Some of you may be familiar with this if, once I show you the pictures and stuff. Some of these techniques may work or may not work for you depending on your situation. Each of these techniques requires, the use of your arms and legs in varying degree, depending on which technique you are using. I think the technique that will more likely work is the technique that takes advantage of the person's stronger muscle groups. Those muscle groups that are not affected by the myositis. So if one of their knees is still strong and able to help, the forward method using a knee may work. If their arms and elbows are also strong to help, they can use the arm and elbows. Like let's say for IBM, they can't use their legs to help, maybe they use their arms. So let me show you the first one. This is the forward method using the knee. As you can see, they can roll. They need to get to a crawling position with this technique. So once they get to a crawling position, they crawl to a nearby stable furniture or a staircase or low sofa. They get to this kneeling position in number 5. They're pushing up on the sofa, bring the stronger leg forward, and use their arm and the stronger leg to stand up. Well, the caregiver can stand right here on this side, kind of like, don't hold here. Put your hands on the shoulder blade area and use the gait belt and lift up. Now, patient may not be able to get to a crawling position or even crawl because they're injured or they cannot get up because of weakness. Maybe once they get to this, once in this position, you can put like a sheet under them, and you can slide them on the floor to a nearby staircase or low sofa, so they can do this technique, or if any one of you any experience with this, yeah,
Sometimes we bring the chair to them.
yeah, that's.
If it's somewhere in a house where the furniture that they might want to use is too far away.
Right, yeah, that's another way of modifying this technique. Yeah, this is the one. Oh, I can do it. Okay, so again, this is the same technique with a caregiver assistance, helping them to roll, get to a falling position, and then push up. This next technique is the backward method using arms. With this technique, they don't get to a crawling position. They have to, scoot back on the floor until they reach a slow sofa or a staircase. If they can put the sofa cushion down, that can serve like a bridge to get onto the sofa using their arm to scoot up. If this doesn't work, there's this equipment that I saw online. It's called Rescue Up, like a step ladder, a portable step ladder with 3 levels. And you can put it against the chair or against the sofa, and that gives them leverage to scoot up to the sofa. And then this last technique is called the hip hike. I saw this video on YouTube, and the title of the video is "How to Get Up on the Floor MacGyver Style."
Yeah.
So if you Google that, there's like lots of creative technique that this is an occupational therapist who created this video. But I just chose this one, but I think the other techniques may not work for patient with myositis. So, yeah.
Ruben, I use something similar to that with my husband Terry. I don't have any quads, so I can kneel in front of the couch at one end, and he can lift my legs up on the couch, and then I can sit. And then I can get up if I roll it or in front of me. So,
Yeah, that's you guys have more creative techniques that I don't know. You can teach me. Yeah.
You can also use this when you sat in a chair that looked like it was going to be firm and stay up, but it's not as firm as you hope.
Right. It's
And this works really well because they can get up to the arm of the chair.
They just have to lift their hips high enough and then scoop over.
Yeah.
Right. Yeah.
Getting up with warrior.
I won't. I wish I had. Yes.
I had a practical experience yesterday. My husband fell in the lobby of the
boy.
Sheridan where we're staying, and I fell too, trying to catch him from falling
Yeah.
with his rollator, and it got ahead of him, and
Yeah.
he tried to catch up, and he went down, and I tried to grab him, and I went down. There we both were on the lobby floor, and he kind of moaned a little, and I looked around, and I got up, and I said, I need a couple strong men somewhere. He was wearing his gait belt, and he knows what to do to roll over and get a knee going. And I had them, and they listened to me. Have 2 guys bring a chair over first, a lowest chair you can find. First, we've got to get him up using his gait belt, not his armpits.
Yeah.
Get him up first onto a chair, which we were successful doing. And then from there, let him sit and relax and compose himself. And then, okay, now we'll do the lift all the way to standing. And they did that. They listened to what I said, didn't want to go their own way. And he was finally standing and with the rollator. And we left and came arrested. We were late for breakfast yesterday. But it worked. And he wasn't hurt. I wasn't. We've taken ibuprofen a couple times.
Well, and I think what you said is so important about letting them sit for a minute, because when people fall, they get shaky.
Yeah.
Even you and I, when we fall, we get shaky.
That's
And
right.
people just want to fix it right away because you're nervous. And just let them sit and do a little calm and then a little more,
That's true.
and you can do so much more.
Yeah, if I had been alone and nobody was there, I would have called 911 and asked for
Right.
assistance.
Gotta be aware of something else. My wife fell in the mall,
Mm.
and she doesn't want help to get, she wants to do it herself. So I was down in there, and I'm getting booed. People are watching and saying, they're giving me a rough time because I'm not helping them.
Well, oh my God.
Yeah, it's bad.
That's
When I'm
bad.
carrying the luggage, my husband gets the dirtiest looks.
Yeah.
Uh, You just don't know how, you know, it looks fine outside, but you know, it's cheating. Any other questions with this technique? I think all you guys know those three techniques that I've shown. We're moving on to the equipment part. Now, your question about the Hoyer lift, one of them is the Hoyer lift for a more dependent person. I have used it before, you know, you have to put these pads underneath them. And then,
I use it, I need better instructions as to how to position the person, especially when they're on the floor.
I see.
Which way should they be pointed?
Mhm.
Is there, you know, anything that I should know about?
Right.
That might help me get them onto the Hoyer lift?
Is the person getting therapy, physical therapy?
Yeah,
You can
that's
probably-
physical therapy. I guess I'm gonna bend his ear the next time he shows up.
Yeah, you need to show you how to use it.
He used it fairly well, but I nearly threw my back out the last time he fell on the floor and I didn't get him.
Yeah. So we have this chair booster. It's called Caboost. You can think this is the height of the chair to like 4.5 inches to help you getting up. And then we have this lifting seat, spring-loaded. Some of them are electric version that helps you to get up on the chair. And the Hoyer lift. You have this extra thick seat cushion. It comes in different height, helps you with getting up in a low chair, and then this board. This Gentle Boost uplift assist. 3 days ago, I have an IBM patient come to the clinic, and he showed me that he purchased one of these at home. He said that you can collapse it. It's portable. You can take it with you when you're traveling. It's a spring-loaded. It goes up as you lean forward and try to stand up. That thing here will lift you up and get you up to a standing. Helps you to get up to a standing position. And then you have this like an inflatable cushion. You fall on the floor. It comes with an air compressor that inflates the vessels and sit you up, raise it up to like 22 inches height, as long as one person is behind the patient and then helps you to get up.
And anyone seen one of these?
Yeah, they also have them now that have a back, so you can do it by yourself.
Yeah, there's also the one with the back cushion or something, like an inflatable. It's costly though, right? It's an expensive
Yeah,
one.
none of these things are real cheap.
Yeah, they are.
And as a word of caution for the folks with IBM, that as their core stability loses function, things that dump you, easy ups, that
That's-
gentle uplift, those
That's true.
dump you.
That's work.
So-
Yeah.
Looking for things that go straight up are a lot easier.
That's one of my, most common question I get from the clinic. Do you know of a device that instead of pushing you forward, lifts you up first to a height and then helps you? I haven't seen any.
They have one.
And yes, you guys would know.
Yeah, there is one, it's like a dolly,
Uh-huh.
and it has a platform, and it actually has a remote control. It's about $2,000,
Wow.
but you can keep it in your house, and literally, as long as you can scoot your butt onto the platform,
yeah.
it goes straight up just like a dolly, like a forklift.
Like a
almost.
forklift, yeah.
Yeah.
Do you know what it's called?
Something lift, if you just put help off the floor in Google, it comes up, but I'll find it on my phone and tell you.
Yeah.
Lift assist or something. And it's
Any
pretty-
question? The back?
Is that the one you looked at the other day? The human lift something?
Yeah, human lift.
Isn't that guy out there with that toilet that goes straight up and down, one of his products is one of those?
Oh, really?
Yeah.
Yeah, that would be,
Not the toilet, not the one that just takes you off the ground, but that one that,
Goes
looks
up.
like the toilet's this high. I think one of that company's products is what she's talking about. So.
and this is called the Ripton Tram. This is a walking and transfer device that physical therapists use in the clinic. So it's a battery-operated patient lift. You put like harnesses, strap it around the thigh and pelvic area, and you push a button, and it lifts the patient up to a standing position. And once they're in standing position, as long as they have enough legs, then they can help them walk. The only thing with this, with my experience using this device, is if the patient cannot lock their knees, it's hard for them to stand up. So they'll be like, getting a wedgie from the harness, So, but I do have a myositis patient who in the beginning cannot use this one because of the leg weakness, and we started with standing frame. If you ask your physical therapist, there's a device called a standing frame. It's actually like a device that blocks the knees and has harnesses on the hips and pelvis and just stands you up, with some support in the front for your arms to lean on. And it builds up your leg strength just standing there, especially for IBM patient or polymyositis. They tend to go this. So that standing frame, pull it up, and block your knees, and it makes you stand for a period of time. And I started that patient in that standing frame for months. And then she was strong enough that one day I started putting this on, and she was so happy that she's walking. I have actually, my last slide is, I asked her permission if I can videotape her to show it to you guys, how I use this device in the clinic. So this is the last slide. She made it.
If that person couldn't walk at all,
Yeah.
could you pull that person in that device?
Yeah, so
They have wheels.
you got wheels. So so you allow them, you don't pull them, you allow them to walk, and then you steer the device and kind of like guide them to, and, yeah.
What I'm wondering though is, would it take the place of a Hoyer lift?
No. Because I don't think this can only accommodate like 300 pounds direct lift, and the way the straps is put, it's around here, and it's really uncomfortable, even with getting up, pulling up to standing. As they get stronger, they depend less on the support. They do more of the weight through their legs. Yeah.
Is that primarily a rehab device? That
It's a
would be
rehab
something you use in your home?
This is primarily a rehab device, but you can have a home therapist eventually, to train you how to use it. Because with this patient, you can see how weak she is, and I need to be there all around her. I cannot recommend this to be used at her house. She needs to get stronger more. That her body needs to handle it better.
They have similar portable ones of those that you can put in the trunk of your car for getting people from their wheelchair to the car, to their, that kind of stuff. And they fold pretty small.
Pretty small.
Well, relatively speaking,
Relatively
pretty
small,
small.
yeah.
But yeah.
So, and thank you so much.
Thank you.
Thanks.